Hello and welcome to the 2023 speaker series for Autoimmune Encephalitis Awareness Month. My name is Tabitha Orth. I'll be your hostess throughout the 6th series this month. This is our 4th speaker, and I'm founder and president of the International Autoimmune Encephalitis Society. If you look down at the bottom of your screen, you'll see a question and answer box. So as we go through the presentation today, as questions arise, go ahead and put your questions there. We'll get to them as many as we can at the end of the presentation. For those of you who are patients or family members, we have to ask you to not ask a specific question about your case, so make your question general so Dr. Santoro can give it his best shot, all right? Today's presentation is on pediatric autoimmune encephalitis, and Jonathan Santoro is here with us. He serves as director of the Neuro-Immunology and Demyelinating Disorders program at Children's Hospital in Los Angeles. And he's also an assistant professor of neurology at the Keck School of Medicine at the University of Southern California. Dr. Santoro completed his undergraduate master's and medical degree at Tulane University. He subsequently completed residencies in pediatrics and child neurology at Stanford University School of Medicine, and then subsequently specialty training in neuroimmunology and pediatric multiple sclerosis at Harvard Medical School. He's a passionate clinician scientist who has published over 50 peer-reviewed manuscripts, and as is only one of a handful of national clinician scientists who treat neurological disorders associated with Down syndrome. He currently serves on the American Academy of Neurology's Health Policy Subcommittee and as a representative of the AAN to the American Medical Association. Dr. Santoro is a longstanding advocate for persons with disabilities and has lobbied locally in California and on Capitol Hill. He's adjusted his schedule to be with us today, and so we greatly appreciate him joining us. And with that, I'm going to hand it over to you, Dr. Santoro. Thank you so much for joining us.
No, thank you for having me, and I appreciate the warm welcome. And we're certainly going to have a very broad talk today on pediatric autoimmune encephalitis. Now, I will say this before we get started. This is a talk that I should probably be taking 4 to 5 hours to give you. As you've realized, if you're on this call, autoimmune encephalitis is a complicated disorder. It's a heterogeneous disorder. And we're going to go over some of the nuances of it and why it's so unique in young persons. And then at the end, I'm hopeful to answer any questions that the audience may have about diagnosis, workup, or really where we're moving as a field. So the objectives today, we'll talk briefly about why autoimmune encephalitis happens. We're going to focus mostly on NMDA because that's the most well-studied autoimmune encephalitis, as many of you are aware. We'll review some of the common neurologic and psychiatric features. We'll go over the diagnostic criteria. We'll talk about how to evaluate and discuss multiple different treatment avenues. And then we'll talk about some of the long-term physical and neurologic outcomes and how to treat some of those as well. So let's start off with what this condition is. And with regards to epidemiology, we know that autoimmune encephalitis is quite rare. So we're really only talking about 0.1 to 0.2 per 100,000. And when we really break it down further, the incidence from some of the larger studies in Denmark report even lower rates than that. And I think that, this is a disease where we always talk about how can physicians not know about it when we're having those initial symptoms, but really this is something that unless you're a neuroimmunologist, you may only see a handful of cases during your career. NMDA receptor autoimmune encephalitis was the first reported, that was back in 2007. For those of you that have read the book or seen the movie Brain on Fire is based on that. But these are interestingly individuals who present primarily with psychiatric issues when they first are noted to have symptom onset. We also see that this is a disease that primarily affects females, with up to 40% of individuals having onset less than 18 years of age. We'll talk about some of those gender differences at both ends of the age spectrum. And up to 40%, although this number seems to be swinging all over the place lately, are associated with benign tumors, and that's what we call paraneoplastic disease, and we'll talk about that a bit in a moment. So when we talk about the age distribution, obviously there's kind of this big clustering of individuals really from the preteen years through about age 40, and then really things kind of extinguish towards the later years. So kind of 40 and up, the total number of cases drops off quite a bit. I think one of the things that I want to point your attention to is the male to female ratio for our youngest patients is actually still skewed towards females, but much closer to 1-to-1, as opposed to those 3-to-1 or potentially even higher ratios that we see in the 11 to 20 and the 21 to 30 age groups. Another thing that I want to point your attention to on the right side of the screen there is that the initial presentations are often less severe. So there's less disability associated with those earlier onset presentations. Whereas if you're unfortunate enough to develop the disease a little bit later on in your life, you can see that those MRS scores or the modified Rankin scores are much higher, indicating a higher disability assessment. And that's at the onset of the symptoms. So how does it actually happen? I mean, there's a few different ways, and we won't spend the majority of this talk going into all of the nuances of molecular biology, but basically antibodies are created through a process typically of either molecular mimicry or epitope spreading, or a combination of the two, against either an infectious or a neoplastic cancer agent. So these are basically proteins, either they are virus or cancer, that are expressed in the bodies. The immune system recognizes them and then creates pathologic antibodies that bind to both good tissue, which is yours, and then the bad tissue, which is either the tumor or the infection. Although the exact autoantibodies can differ, specifically for NMDA, when those receptors actually bind, so the pathologic antibody binds at the receptor for it, it causes internalization and it causes changes in the electrophysiologic state, which is why you see seizures as a common presentation in NMDA receptor encephalitis. And although these receptors are located throughout the body, there is a clustering in the central and peripheral nervous system, which is why we see some of the symptoms from there. I think this is a good diagram of kind of where and how these cells are actually creating problems. So you can see here's a demonstration of a neuron sitting in the hippocampus, and you can see the NMDA receptors are right on that neuron. So when the antibody or the problem-causing antibody gets up into the brain, it binds right at the neuron or the cell, and then it can cause cellular disruption from there. This is a much more detailed diagram, and of course this is kind of showing things from the very start, is that essentially if we're talking about a patient who has a tumor or a benign tumor, such as a teratoma, those antigens, those proteins that stick off of the tumor, are recognized by the immune system. The immune system does what the immune system should do, is create extra antibodies to attack that tumor. But then, as you can see on that right side of the screen, those antibodies get up, they accidentally get into the brain, and then they start binding into the wrong places. So while it's easy to just say, well, we know that there's an antibody with many of these autoimmune encephalitides that must be the only cause of the symptoms, it is a little bit more complicated than that. So on the left side of the screen, you'll see something called the classic complement pathway. So this is actually when the antibody binds the proteins, and specifically those are the receptors in the brain, it activates a whole cellular cascade that can lead to cell death. That's one side. The other side too is that we always talk about B cells. B cells are the ones that produce antibodies very broadly. T cells can also get activated by B cells as well. So you get this kind of feed forward mechanism where there's multiple different causes of inflammation in the brain, initially probably through a more B cell or antibody mediated pathway, with then complement and then T cells picking up some of the immune activation after that. So briefly, we'll talk about some of the clinical phenotypes. And I think the prodrome is something we always talk about, although at the time that the prodrome is actually hitting, we often don't really say, oh, well, this is going to clearly turn into autoimmune encephalitis. But this varies across studies, but up to 70% of patients will report that there's some type of viral-like phenomenon, headache, nausea, vomiting, upper respiratory tract infection, fevers, or myalgias prior to the onset of any of the neurologic symptoms. And even when they are tested for these things, there's actually usually not a particular infection that is identified, nor does that really matter if we're kind of talking about our pathophysiologic mechanisms that I just referenced. It's not what the actual immune system sees as the problem, it's what the immune system does with that response subsequently. In that green bar, we see that there's an absence of neurologic symptoms for a period of time. This can often be a few weeks. And then in adults, often psychiatric symptoms. In children, it tends to be more encephalopathy, neurologic symptoms, but these will kind of subacutely come on afterwards. I think this is one of my favorite graphs. It doesn't capture exactly how the disease progresses in every single patient, but really you get this kind of falling off a cliff phenomenon, where really a lot of the neuropsychiatric symptoms, the delusions, the hallucinations, psychosis, changes in speech, altered mental status, dive right off into the overt neurologic symptoms, which typically will land patients in the hospital. Obviously, when we treat patients, we want to see that curve go right back up to that orange area. And ideally, if we can identify things early and treat aggressively, we can reduce some of those prolonged deficits. So this is a lovely article written by one of our fellows, kind of talking about what are some of the common neuropsychiatric and neurologic signs and symptoms in AE, so specific to children, and really behavioral personality changes and irritability. I think this is one of those things that gets, chalked up to being normal childhood, but irritability in a child who is not really irritable or is not easily agitated should be a sign that there is something going on. We see that the usual psychiatric comorbidities, depression, anxiety, delusions, hallucinations, and sudden onset obsessive compulsive disorder or psychosis is quite common. The psychosis piece, as we'll talk about in a minute, is extraordinarily rare in pediatric populations. So if that is being reviewed, we tell everybody that that should be treated as autoimmune encephalitis until proven otherwise, because it's just such an unusual finding in children. We can also see that there's rapid weight changes. Often this is in the direction of anorexia. And this is not a refusal of food anorexia, just an actual loss of appetite where the patients will almost look like they're wasting away to some extent. Seizures can also be common, especially in pediatric populations. These can be generalized or partial seizures. Partial seizures meaning that they're happening on one side of the body. In addition, we often see movement disorders. We can see athetosis, catatonia, chorea, dystonia, dyskinesia, and these are all very specific findings, but really these are uncontrolled, non-purposeful movements for the most part. The dystonias and dyskinesias are usually forced muscle contractures when you're doing an activity or initiating a movement. Catatonia is often a stiffness. I like to talk about it almost as being a mannequin. You can actually manipulate the arms into different directions. And then chorea or balismus is when those movements are actually uncontrollable and are large amplitude. Oops. You can also see memory deficits, cognitive impairment, or in children, a developmental regression. So for instance, a child who was formerly potty trained is now not able to do that, and it's over a very brief period of time. We can see that there's language changes. We can see that there's balance changes. And really one of the things that I think it gets missed a lot is the sleep disturbances. So often these will precede all of the other symptoms in pediatric populations, but you'll see that there's circadian dysregulation where sometimes patients will stay up all night and they'll sleep during the day. There's hypersomnia, meaning they sleep up to 20 hours a day, or insomnia, meaning that they're not sleeping at all. And finally, there's this decreased level of consciousness, confusion, or unconsciousness. This is much more common pediatric onset disease, and the term that gets used very often is encephalopathy. This is just another graph just showing that psychosis in general is quite rare in children, even though it's probably the thing that gets talked about the most. Agitation and those mood changes are really the things that we want to look for in children. So when we talk about initial presentations in adults, it tends to be more stewing and brewing. So these are delusional thoughts, very psychiatric or psychotic symptoms, disorganized thoughts, fear, anxiety, and mood lability. In pediatric cases, it's a little bit different. So these patients can often come in with irritability, behavioral outbursts, again, that sleep dysfunction or hyperactivity. And children are much more likely to present with a seizure or encephalopathy, that altered mental status at the initial presentation. And, it's interesting is that I sometimes like to say that, pediatric presentations of autoimmune encephalitis are often a little bit easier to pick up because the symptoms are a little bit more dramatic, as we were talking about with seizure or encephalopathy, which are certainly going to bring you into a hospital, as opposed to some of the psychiatric features that we see more commonly in adult patients. This is a busy slide from a very good study talking about some of the psychiatric symptoms that we observe in individuals with autoimmune encephalitis. But I really want to show you is this slide B over here on the right side. And actually, if you look, the non-psychiatric symptoms are very much skewed into the lower level features and in younger patients. And I think that this is kind of a good reminder that often the psych symptoms, as we are talking about here, are a little bit less noticeable in pediatric populations. Again, the presentation, if you do have psychiatric symptoms, can be quite heterogeneous, meaning that they can overlap with one another, they can overlap with the neurologic symptoms, and they can really occur anywhere along this multiple week time frame. The memory deficits and difficulty performing the daily functions, especially in our teenage patients who develop these symptoms, are often the most profound, or the things that really kind of get us worried, as well as speech language issues, which are going to be very present in the school setting. The challenge here is that the symptoms can look fluctuant and may be responsive to environmental stressors. So it's very easy to just say, oh, well, this patient is just depressed, or this patient is anxious, they're worried about their upcoming test. Talk to our trainees about this is that if you're having to explain away multiple different events in an individual's life because of some of these psychiatric features, we may have to start digging a little bit deeper to see if there's a primary neurologic cause. So some of the autoimmune encephalitis red flags, I think this is kind of repeating a little bit, but talking about the encephalopathy, so if there's altered mental status, if there's sudden onset of those abnormal movements, especially if they're mixed features, meaning that there's more than one type, or sudden onset of explosive seizures, meaning that an individual who didn't have seizures before is suddenly having multiple seizures and there's no history of epilepsy. There are specific antibody syndromes that can cause slight differences in some of the clinical features. The reason why I don't want to focus on this as much is because this is really what the clinician should be doing. This is what your doctor or neuroimmunologist should be focusing on when they're trying to figure out which type of antibodies in children. And with GAD65, again, it's a limbic encephalitis. So there's memory loss, there's cognitive impairment, there can be seizures, and quite often there are seizures emanating from the temporal lobe, which is where the limbic structures are, right on the side of the head, and ataxia, meaning off balance or looking drunk. MOG is a little bit of a different story. I won't talk about that as much. It's going to be much more associated with acute disseminated encephalomyelitis, which is not autoimmune encephalitis, but there has been reports of cortical NMDA, which we've been discussing, is in expressive language and receptive language, psychiatric symptoms, seizure, and then the movement disorders that we've talked about as well. There are some less commonly encountered syndromes too that I won't spend a lot. Movement disorders and encephalopathy with the psychiatric symptoms are overlays of all of these less frequently encountered autoantibody syndromes in children. So when you're diagnosed with this, the important thing that you'll hear doctors talk about is, well, what's the differential diagnosis? What are the things that we have to rule out? As I think you noticed, many of the infection has to get ruled out. Is there some type of virus that could be contributing to this? Is this some type of parasitic infection? These are all very rare things, but things that are certainly worked up with the neuroimaging and then the other neurodiagnostics like a lumbar puncture. In children, we're always thinking this would be a primary presentation for leukodystrophies, but as an example, as can mitochondrial disorders or Wilson's disease, which is another metabolic disorder in some situations. Obviously, primary cancer can also be the case in some children, although this is very rare. The caveat to that is that primary CNS tumor or primary brain tumor is actually much more common in children than it is in adults, whereas adults, as I mentioned here, often will have metastatic disease, meaning tumors immigrate to the brain from elsewhere. Severe nutritional deficiencies can also pop up. This is a particularly pertinent issue that we need to rule out for patients that we see in Los Angeles who have recently crossed the border. Obviously, psychiatric disease is what we're talking about quite a bit with this. There is a lot of overlay with neurologic disorders, but again, there's no specific test for psychiatric disease, and thus it has to be a diagnosis of exclusion in many situations, especially in children. And then finally, other inflammatory disorders that may have neuropsychiatric, epilepsy, or other symptoms are important to rule out. And that's really where the neuroimmunologist will come in and help kind of tease out the specifics of these disorders. Don't forget, there are the three types of causes for autoimmune encephalitis. And often when this is diagnosed, the doctors that you'll be working with are also trying to figure out exactly if this is a paraneoplastic, meaning there's an associated benign tumor, which could be removed. Post or para-infectious disease, meaning there was an infection that activated the immune system. Or in many cases, we just say that it's idiopathic, meaning we don't know what the actual association is. But oftentimes it can be very confusing because in the hospital, you may be getting the workup for autoimmune encephalitis, but they're also working you up for cancer and other things like that. And that can seem kind of counterintuitive why they're focusing on two things, but really the doctors are kind of trying to get the exact diagnosis from what is causing the autoimmune encephalitis, and then also trying to get all the data they need about the autoimmune encephalitis to better treat it. An example of why that's so important is put on the right side of the screen, is that if they actually find a tumor and they take it out, your relapse rate is actually quite a bit lower than individuals who do not have tumors, meaning para-infectious, post-infectious, or idiopathic diseases. There are some specific phenotypes, like we mentioned. I won't go into these again. These are just some of the additional autoantibodies that have been reported. Other ones that kind of fall on this spectrum are opsoclonus myoclonus ataxia syndrome, which is associated with another type of tumor or a neuroblastoma. Rasmussen's encephalitis, which is a primary epilepsy type of autoimmune encephalitis or presumed autoimmune encephalitis, and then certainly CNS vasculitis, which is much more of an inflammation of the actual blood vessels. They're distinct from autoimmune encephalitis that we're speaking about here. So I'll talk very briefly about the neurodiagnostics and some of the tests that we use. I really like it because I think that back in the day I played a lot of this particular video game, but really there are many tools to work up autoimmune encephalitis. We have better recommendations for this, though. So Tanya Salucci and the crew of other neuroimmunologists set forth recommendations in 2020. This was published in Neurology, Neuroimmunology, and Neuroinflammation as basically a guide for patients who have a possibility of having autoimmune encephalitis. Now, I'll focus largely on the neurodiagnostics as opposed to the actual blood testing, but really we talk about EEG a lot, but for many of you who have had an EEG, EEG is not being used for detection of seizures sometimes in these situations. So in individuals who have no past medical history, a normal EEG would be expected. And so we actually use the EEG if there's abnormalities, meaning that there's slowing, there's lateralized discharges, or there's other findings, as I've listed here, that can indicate cortical dysfunction, meaning the brain cells are not firing off properly, which can give you kind of evidence that there is an objective neurocognitive dysfunction as well. Now, not every patient will have an abnormal EEG who has autoimmune encephalitis, but it is a relatively good marker for that. In addition, if you leave it on long enough, you can actually detect seizures as well, especially if you're unsure if some of the movements are seizure versus a movement disorder. It can also help rule things out. So we have found that there are some patients where when we hook on these EEGs, we've actually found that they fit better with another type of known epilepsy disorder. So we can rule that out and then treat them more appropriately with that. And I will say this, it's just important to remember there are some individuals who have particular genetic or medical disorders where we expect them to have an abnormal EEG at baseline. This is like Down syndrome, where interpretation of the EEG for the purposes of a diagnosis of autoimmune encephalitis may not be particularly helpful because we know it may be abnormal. MRI is very important. It's a staple. We're looking for that slide A right there with that increased brightness in the medial temporal lobe. We always want to have it on a 3T or 3 Tesla scanner, and that's with and without contrast. The reason why that's so important is we can, one, with the contrast, determine if there's any leptomeningeal enhancement, so breakdown of the blood-brain barrier that we can actually visualize. And don't forget, MRIs can be normal in the majority of cases, but a radiologist is kind of like an art interpreter. And so I think that this is always something where the radiologist will render a report, but your neurologist also should be looking at MRIs as well to make sure that they agree with the findings. Because as you can see, some of these bright spots that pop up are quite subtle. I think that in the future, as we go to higher power scanners, I think that we'll probably find a higher hit rate of abnormal MRIs, but still we're operating on the 3 Tesla scanner for right now. Lumbar puncture, I don't know how to stress this enough. Everybody, if you're concerned about autoimmune encephalitis, needs a lumbar puncture. The basis is that we don't want to see a lot of white blood cells. We only want to see a few, because a lot of white blood type of process going on. The other things that we're looking basically to look at to see if there's a higher rate of protein synthesis in the brain as opposed to the body. We also will often get neopterin in pediatric practice. This is another non-specific biomarker of human monocyte and macrophage activation. And so it kind of tells us, it's not necessarily a smoking gun, but it's kind of the breadcrumbs of autoimmune encephalitis and can be helpful for those kind of borderline cases. And obviously we want to use preferentially a Mayo cell-based assay for the autoimmune encephalitis panel, although ARUP is another option for some individuals. I will say very briefly that we're learning more and more about how the herpes virus is actually related to the development of autoimmune encephalitis, specifically anti-NMDA. And we find that in very young pediatric patients, so we're talking like a year or two, those who have had prior HSV or herpes simplex virus infections actually have a pretty high rate of developing NMDA receptor encephalitis later on. I think this is really activating when the patient shows back up with seizures and encephalopathy, when in fact it actually can often be NMDA receptor encephalitis. And it's probably a case of this once every few years. So it is still very, very rare to even get HSV encephalitis, but it is something that we're learning more and more and may actually be a link to the development of hopefully more targeted treatments in the future. There have been a variety of different papers on this recently. The reason why we don't tend to get them is they are less sensitive in prepubescent children. And the other piece of this too is that it's a very costly test. So they're not immediately available under most health plans. When we use it in the brain, it seems to be quite high. And in addition, actually also be beneficial for picking up unusual tumors or other sites that could be potentially neoplastic in other individuals, especially as the age spectrum goes on, because we tend to see less tumors in children. So what about the mimics? I think that this is something that we're always battling, is that we've found many of these non-specific biomarkers of brain inflammation and other diseases, including schizophrenia, including OCD, but we're really not sure what to make of it at this point. And so this is really why it's so important to actually take the multitude of tests that are obtained and then interpret them in the fitting diagnostic criteria. So I think that this, I wanted to highlight diseases, but really it's using the diagnostic criteria and using the picture that is painted by the results of the different tests that is going to be most helpful to arriving at the right diagnosis. So as far as diagnosis goes, the standard is the Grouse criteria from Franzek Grouse and the Dalmau group that was published in Lancet Neurology in 2016. Although as I mentioned previously, Tanya Salucci published with another very excellent group of clinicians and physicians in neurology, neuroimmunology, and neuroinflammation in 2022, or excuse me, 2020. And as you can see, it's a little bit complicated. So there's a lot of different points along the way where we have to consider autoimmune encephalitis. And I'll draw your attention over to the right side of the screen, because this is the pediatric specific criteria. But essentially, you're basically saying clinically, do you think autoimmune encephalitis is present? And if so, then get the testing, and are the paraclinical tests, so the neurodiagnostic tests that we just went through, are they abnormal? And that's when we start to consider treatment. So again, there's not one specific thing, but we're looking at these criteria kind of to paint the picture. Now, what I do like about the proposed criteria from Cellucci is that it actually breaks it down as probable, definitive, and possible. So because it is so heterogeneous when patients show up with these symptoms. As you can see, we have number 2 being the clinical evidence of neurologic dysfunction. For all categories, it requires 2 or more features. And as you can see down at the paraclinical testing, when you have possible autoimmune encephalitis, you actually don't need any of those tests to be resulting back yet, because that is supposed to be enough to get you to go with the test. But when you get to the probable antibody negative disease, you need at least one of those neurodiagnostic studies, plus or minus the brain biopsy, which obviously we try to avoid whenever we can. And then certainly for the definitive autoantibody positive cases, you want to have ideally an antibody that has been identified. This is a cheat sheet that my fellow Dr. Jaspor had made for one of our review articles a while back. But I think that you can see it becomes less when you're trying to make that probable case. You need either this lumbar, patients are not going to be getting that biopsy. But again, those features, those clinical features that we were speaking about earlier, are relatively straightforward and are easy to actually put together for the majority of patients, and are inclusive across multiple different phenotypes, multiple different antibody types as well. This is pulled from the older criteria by Grouse. I just wanted to include it for the purposes of being thorough. For the possible diagnosis, it's actually quite similar. It still requires one of the in the Cellucci criteria to clinical features, whereas the Grouse criteria have it listed kind of all pumped into one. And then probable autoimmune encephalitis, very similar here. You still need one of those neurodiagnostic studies and exclusion of others. A question I get asked a lot is, can COVID-19 cause autoimmune encephalitis? And the answer is maybe, but it seems to be pretty rare. So the acute symptoms of encephalopathy, whenever there's a COVID-19 infection, are presumed to be related to COVID-19 until proven otherwise. But there have been a number of cases, and all case reports, and not anything really super large scale or definitive, to say that there actually seems to be a number of immune activations which cause a traditional autoimmune encephalitis afterwards. This seems to be extraordinarily rare in children, but is more commonly reported in adult patients. And our study out of the Mayo Clinic reported that this was as high as 3% of all samples, although there's a huge selection bias for who is sending samples out for the purposes of these evaluations. That being said, the traditional immunotherapy is associated with COVID-19, which just seems like it was such a long time ago now, but certainly it's still present in. So we'll move pretty quickly into therapeutics. So I think this is one of my favorite graphs, and really focused on both halves of this slide right here. So realistically, rituximab is the medicine that we use that is IV, and it destroys B cells, so the cells that produce antibodies. And we see that now most patients are getting very early in their clinical diagnostic journey. In addition, as you can see, we're also seeing that the relapse good things. We want to see the correct therapies being used, and we want to see the relapse rates going down. Some of this has been explained as a possible immune tolerization. So if you can give a medicine that wipes the slate clean from the immune system standpoint on their ability to make new antibodies, that would be natural to explain why the relapse rates would go down, but that has yet to be shown. As with the diagnostic criteria, the treatments are even a little bit more complicated. So I think Nasandi's study from 2021 was excellent in terms of providing a very comprehensive review. But because this is a little bit complicated, I'm going to focus on the big four, so to speak, of what we often will see in the hospital system. So the first one, as you can see in the bottom right-hand corner over there, is Solumedrol. So IV steroids are often used even before the diagnosis is actually rendered. It works for a variety of different neuroimmunologic disorders and neuroinflammatory disorders. And to be very honest, it's not the most effective medicine in the hospital, but it also buys us time while we're waiting for some of those results to come back. On the bottom left, you'll see GammaGuard, which is a type of intravenous immunoglobulin. This is often previously administered kind of almost immediately after Solumedrol in many cases, but IVIG takes a while to work. It has immediate B cell effects, and it also has some longer term T cell and immune regulatory effects as well. But we've actually moved a little bit away from using IVIG up front and really kind of focusing on the other two up there after the steroids and the diagnosis is confirmed. In the top right, you see plasmapheresis, meaning we actually suck out the antibodies and then give the blood back to the system after we've kind of taken them out. That's the fastest way to reduce autoantibody pathogenicity. And then, as we talked about already, rituximab is a B cell depleting therapy that is technically a chemotherapeutic, kills B cells, which are the cells that create antibodies, works very, very quickly over about a week. Some of the alternative therapies that we've used in both severe cases and more long-standing cases, mycophenolate, which is also called Cellcept. We are using anakinra and tocilizumab. These are IL-1 and IL-6 biologic therapies. Bortezomib has also absorption has been a newly reported on therapy, although I don't know if any centers are really using this in common practice at present. I think one of the key pieces here to remember is that everybody's treatment is going to be a little bit different. And I think that this is one of the challenges is it is certainly an apples to oranges comparison when you're talking to other individuals who have had a child or a loved one who's been affected by autoimmune encephalitis, is there are reasons to jump and move around this protocol. So while Nasandi created a very beautiful diagram with color coding, there are clinical and diagnostic reasons to move around in this protocol as well. So very rarely are you going to get patients that have received exactly the same therapeutics in exactly the same order at exactly the same time. So some of the other questions that I get quite a bit, is there a best treatment? Depends on the patient, but in general, there's no controlled study to support one over the other. Is more treatment better? Yes and no. So we want to be very aggressive with how we treat autoimmune encephalitis, but we also encounter this concept called the treatment paradox, where patients who have more severe disease are able to avoid some of the heavy-duty treatments if you have more mild disease. Is there a best order for treatment? Probably, but we're not really certain. This is why you'll often see doctors proceed in a very stepwise manner. We try to respect the guidelines of first, second, third, fourth, and fifth line therapies. But as I mentioned, there's reasons clinically to move around in the protocols as well. One of the things that I want to highlight here on the right side of the screen are actually much lower than obviously the no treatment group or only a first line therapy. So this would be the difference between just receiving steroids or receiving steroids and rituximab. So we'll talk about some of the longer term complications. So early in the disease course, you can actually see a variety of different psychiatric and movement disorder issues: catatonia, altered mental status, agitation, chorea, dyskinesia. I'll talk about some of the medications and different symptoms that may pop up during the hospitalization. So obviously, we talked about and autoimmune encephalitis, especially in children. There's no specific protocol that we generally use, but we have gotten in the practice more of trying to avoid medications, especially anticonvulsants, that may cause more agitation or psychiatric symptom worsening. And so using medicines like valproic acid, benzodiazepines over some of the other medications that I've listed here are being a little bit more commonly used, but certainly levetiracetam, which is also called Keppra, still gets used a lot because it's such a safe medication as far as anticonvulsants go, even though it can cause some worsening of psychiatric issues. We also have to administer a lot of antipsychotic agents. So for those of you who have had a loved one who's been in the hospital, the delusions, the hallucinations, the agitation, the aggression are all very aptly treated with antipsychotics, but these can unfortunately lower the seizure threshold. So your neurologists and your psychiatrists are often having many hot debates behind the scenes regarding which medications are least likely to lower the seizure threshold. Not that many patients are on antidepressants in the hospital, but even subsequently after discharge, we do have to watch for some of those medications as well, given the long-term risk of epilepsy in this population. In addition, when you use antipsychotics, they can actually worsen some of the movement disorders. But we'll talk about that on one of our subsequent slides. Agitation in the hospital can be quite bad as well. Obviously, antipsychotics can be used for that as well, but you'll often see patients on alpha-2 agonists like clonidine, gabapentin, valproic acid, and benzodiazepines, especially when there's seizure activity or antipsychotics. The movement disorders that we see in individuals with autoimmune encephalitis, especially initially, can be chorea, dyskinesia, and really can be quite bothersome to the patient and agitating. Remember that the language that we use actually matters. We don't kind of lump these all in together. Chorea is this non-purposeful dance-like movement, whereas dystonia is this sustained muscle contraction with the initiation of another movement, and dyskinesia is any excessive, abnormal, involuntary movement as well. The common medications that we use for that are, again, benzodiazepines, if you're not noticing a common theme across all of these different treatments, baclofen, trihexyphenidyl, and then for status dystonicus, being the most severe presentations of the movement disorders, as you saw with that individual lifting off the bed, IV dantrolene can occasionally have to be administered as well. So the use of antipsychotics is somewhat controversial. So as I mentioned, they get used for a lot of different reasons, a lot of that being related to agitation, delusions, and hallucinations. There is a risk benefit, but they can make some of the movement disorders actually a little bit worse, and there is a risk threatening. There seems to be a relatively high rate. The only data that we have on this was from a study from 2017, where up to 22% of patients developed these types of symptoms when an antipsychotic was used in the context of having autoimmune encephalitis. Generation antipsychotics, but still, it's a pretty high rate and something that we really need to watch very closely for. And this is where kind of having psychiatry and neurology interfacing on your loved one's case is so particularly important. When we get into the acute management, we talked about many of the different medications already, but really chronically, individuals will often end up on mood stabilizers or antidepressants after they leave the hospital, depending on the clinical features as well. There have been some case reports and series of ECT, both for malignant or refractory catatonia as well in the context of autoimmune encephalitis. But really, psychotherapy is just not something that's going to be super effective in the acute setting. The late phase cognitive and behavioral sequelae, I think, are the most challenging to deal with. And don't forget, I mean, in an individual who has a stroke, we know that you're supposed to be left with some deficits. Autoimmune encephalitis is one of those silent diseases where it's not, or I shouldn't say silent, it's an invisible disease sometimes, where a lot of the long-term issues can be more cognitive in nature. So this can, present itself as executive function problems, memory issues, impulsivity, sleep problems, and very rarely we've had some patients who actually have a Kluver-Bucy phenotype, meaning that they're hypersexual, they eat a lot, they sleep a lot. Obviously, this causes a lot of physical disruption in an individual's life as well. But long-term, the prognosis is getting better. This is not designed to scare anyone. I think that in children where the pages the pages are still yet to be written in terms of the long-term prognosis, but I think the good news, things on the horizon are that neurologists, pediatricians, neuroimmunologists are recognizing these conditions. They're treating them aggressively, and we're seeing very low relapse rate with excellent neurocognitive outcomes long-term. But that being said, there's still about 10%, 15% of patients that have very severe disease. They're refractory to some of our treatments, and the advancement of knowledge, especially regarding therapeutics, is still an important piece here that we need to focus in on. So with that, I'm happy to answer questions and discuss anything that would be of interest to the crowd.
I'll read the first question for you. Just like HSV can trigger NMDA encephalitis, can other viruses trigger an autoimmune encephalitis that is antibody negative? We've had a few cases of severe encephalitis presentations, chronically ill, intubated seizures with positive rhino, entero, and other basic viruses that wouldn't necessarily present as severely, that have responded to steroids, Plex, IVIG, etc., but no antibodies were detected. Is it reasonable to try such patient presentations with immunotherapy?
Yeah, it's a great question. So the way that I would answer this is the immune system doesn't really care what the initial offender is, whether it's HSV, whether it's EBV, whether it's CMV. That is really the most important piece. Now, there are certain diseases like multiple sclerosis that clearly have a direct association with a protection for certain neuroimmunologic phenotypes associated with particular viruses. But as we've seen with COVID, anything can trigger these processes off quite a bit. I think that in general, if you're on the fence about is this infectious or is this post-infectious or autoimmune encephalitis, these are the situations where you really want to have close collaboration between the neurologists, the infectious disease doctors, and the psychiatrists as well, because one of the things that we always have in the back of our heads is you don't want to treat an infectious process with immunotherapy, which would suppress your body's ability to fight off an infection potentially. So complex decision making, and another reason why you see that there's some jumping around in terms of the treatment algorithms for sure.
This next question, I don't know if it's too specific. What's your recommendations for subsequent treatment when a pediatric patient with GAD65 positive AE still has symptoms after 5 years of high-dose IVIG, and that's treated every 4 weeks? What is your experience with plasma exchange in a case like that? Does CHLA do plasma exchange for chronic AE or just acute cases?
Yeah, so we tend to keep plasmapheresis for acute inpatient hospital type of situations, although technically we can administer outpatient. I think if you're in a situation where, and this is just general advice, this isn't particular to GAD65, but if the IVIG is not able to be weaned off, then you need to use something that is more directly immune suppressing, like a rituximab in that situation. We've also had some patients have long-term success with mycophenolate. So it just depends on the patient. It's a great question for the neuroimmunologist that's treating you.
Right. In cases of refractory NMDA, how do you know, quote, when to stop immunotherapy when patients have continued symptoms, significant dystonic storm, dysautonomia, I am always...
Dysautonomia.
Thank you. I still have issues with pronouncing some things after my own AE for over 2 months. Is there a role of continued trial of newer agents as time progresses and no improvement are seen after second-line drugs have not helped?
Yeah, I mean, this is a complicated question. I think that, historically, no, we stopped. We stopped when we got to second line because we didn't know what to treat. I think now there's enough literature, even in pediatric cases, to support pretty aggressive treatment. The challenge becomes we don't know at what point we are dealing with the sequelae of the autoimmune encephalitis, meaning the damage has been done and we have to just recover from it, versus what's actually active. For instance, we've used medications like cyclophosphamide, which don't get better. And I think in those situations, we say, all right, well, we've tried our hardest with the immune treatment. This seems to be like we're dealing with the leftovers of the original inflammation.
I think that's one of the
Not
most
a
challenging
patient.
areas for the clinician, don't you? Yeah.
Yeah.
Is rituximab treatment contradicted for patients with underlying chronic infections due to the effects of immune system, specifically for a child 10 years old who hasn't reached maturity of their immune system? That's a good question.
Yeah, so it's not contraindicated. So we use rituximab down to age 2 when we've had to. It's not something that we like to do, but I think you have to look at it as a risk benefit, right? So obviously chronic infections, we don't want to suppress the immune system to an extent where that becomes a problem, but every patient will be a little bit different. But I have not, the issue that we encounter is that we have to give repeated doses of rituximab or a B-cell depleter. The risk of something called hypogammaglobulinemia increases, especially if you're prior to puberty when you're receiving it. But we have to weigh that against the possibility of brain damage as well.
Mhm. For non-textbook cases of AE, can you talk about other biomarkers you might find helpful? For example, what about AB42, myelin basic protein or neurofilament light chain in the CSF?
Yeah, so I think that those specific 3 biomarkers are not ready for prime time. So amyloid beta 42 is not something that would be useful in determination of autoimmune encephalitis. That's an Alzheimer's disease biomarker. Myelin basic protein can be helpful. Neurofilament light chain could be potentially helpful. Neopterin, which I mentioned in this presentation, can be helpful. Even CXCL9 or CXCL13 can be helpful. But again, this is kind of the art of medicine, and actually get them to link in to say, does this tell a story of autoimmune encephalitis, or is this trying to tell us that maybe something else is actually causing these symptoms? Great question.
Yeah. Has there been a recent increase in autoimmune encephalitis? This person is asking because they've seen 4 NMDA patients in the last 10 months. What could be contributing to an increase in autoimmunity?
So I have 2 answers for this. One is I think we're getting better at diagnosing.
Ah, good.
To this condition. So I joke with our trainees here that November, December, and January is NMDA season. And that's just is the way it's been at Children's Hospital Los Angeles for the last 3.5, 4 years. And I don't have a great explanation for it. We assume that it's related to the viruses that are going out in the community, but it's definitely, we see these unusual swings from time to time for sure.
Interesting. This person is saying Plex is difficult to obtain. Is this reserved for hospitalized patients, or could this be done as an outpatient, and at what intervals? For how long?
So Plex is it's a diva procedure because it's very involved. You have to get a central line. It's a big deal. So it's often utilized in the hospital when you have access to all of the resources under one roof. Outpatient, it can be done. It's very challenging technically. It's very costly. And it depends on the patient for how frequently you have to do it. Hypothetically, it should last as long as IVIG does. It should be like a once a month type of situation, but everybody's protocols are different. We don't offer it unless it's a really unique situation for that reason.
And our final question is, have you tried intrathecal rituximab for refractory NMDA?
Yeah, so we have not. There have been some published studies on this, again, case series level. I think that the challenge here is we know that the brain has some privileged immune sites where, rituximab is killing all the B cells in the body, but for those small populations that may be existing in the brain, they still may be able to produce antibody. I think that this is something to at least bring up with your clinicians if you're having a seronegativity in spinal fluid or on the lumbar puncture and continued symptoms.
Really fascinating. You were touching us just on this a few minutes ago. So how do you treat the residual damage?
Yeah, it's a great question, and I wish I had a better answer for you. So a lot of it is just symptoms. So if you have epilepsy, we treat your epilepsy with anticonvulsants. If you have depression, anxiety, we treat you with psychotropic medications. I'm hopeful that what we're going to find is that certain medicines are neuroprotective up front in the future, but we still don't know which medicines may be able to limit the amount of sequelae. But for right now, it's just symptom management, unfortunately.
There's one final question. Let's just go for it. People are going to still ask questions. Let me take a look. Let's make this the final one. All right. Could a child present with seizures and movement disorder almost 2 years before an acute presentation of encephalopathy and all be due to an autoimmune process, or more likely that they may be two different diagnoses?
That is a unique question. So,
yes.
I mean, to have two ultra rare diagnoses in a child is probably less likely. So applying an Occam's razor approach, one would want to assume that they are related until proven otherwise. But I think that this is challenging, is that when the initial presentation like that comes up, I'm sure seizures and movement disorder are kind of linked in. There is an association between a variety of different genetic disorders that can be associated with that. But then with the encephalopathy presenting later on, it's an interesting thing that would be hard to rectify as two independent things. One of the things that we're focusing on at CHLA is looking at the genetics of individuals with these types of conditions and finding that there's actually quite a few variants of unknown significance with these atypical, so to speak, presentations, as Zoe was mentioning here.
And just as a final comment, one of the attendees wanted to say that this was a fantastic presentation.
Oh.
And wanted to thank you, we appreciate that. Thank you so much. John, we really do appreciate the time that you've taken to spend with us today. It's really been tremendous, and it's going to be such a big help to clinicians and families moving forward. So thank you so much. And we're so glad everyone could attend live, and this will be up as a recording soon. So watch for that on our YouTube channel. Okay. Thanks, everyone.
Thank you, everyone.
John. Bye-bye. Yes.